Welcome to Menopause Made Easy Part 6. This will be the last of the series on menopause. I will be sharing with you the Women's Health Initiative study 2002-2004 and how this study shaped the way doctors prescribe HRT in relation to menopause since then. Again, they studied the risk and benefits of estrogen plus progesterone and as well as estrogen alone in healthy postmenopausal women. We will be concerned with the first two arms of the WHI study. The first arm is estrogen plus progesterone, looking at coronary heart disease. The second arm is estrogen only or Premarin on coronary heart disease. The first arm is a placebo-controlled study in 40 US centers. Approximately 16,000 patients were randomized and follow up for an average time of 5.2 years. The target variable, the primary prevention of coronary heart disease in healthy women. The second arm, estrogen only in women who's had a prior hysterectomy, 10,739 women, average age of 63. You could hardly call these healthy because these days you won't even consider HRT treatment or estrogen treatment for a woman age 60 and above because she's quite late in her menopausal time frame. And the study was terminated prematurely after an average follow-up of 6.8 years. And these were the results. In the estrogen and progesterone arm, there were 7 more cases of coronary heart disease per 1,000 women. I mean, we were expecting it to be low, isn't it? Because we had earlier said that estrogen was cardioprotective, but what they found was that there were 7 more cases of coronary heart disease per 10,000 women. Stroke, 8 more cases per 10,000 women over the 5.2 years. 18 more venous thromboembolism, which is not surprising, but the surprise was the first two, the increase in coronary heart disease and strokes. 8 more breast cancer patients out of 10,000 people in over 5.2 years. That's not surprising. 6 fewer colorectal cancer, and obviously less fractures in terms of the hip fractures and all fractures. In the estrogen-only arm, women who's had hysterectomy, no difference in terms of coronary heart disease, 12 extra cases of stroke per 10,000 women. They will follow up for an average time frame of 6.8 years. 7 more venous thromboembolism. In terms of breast cancer and colorectal cancer, no difference. And obviously there were a lower incidence of fractures. So, yes, there was surprising findings in terms of there was more heart disease cases where you were expecting it to be cardioprotective and have lower incidence. But then you look at it, the demographics, the baseline characteristics of the patients, mean age 63, past or current smokers, about 50% of them. Women with hypertension comprise 36% of the study population. Women who use lipid-lowering medications, 13%. Previous cardiovascular disease, 20%. Overweight, 64%. 20% had a high cholesterol, and 4% were diabetics. So, are these women healthy? I don't have the answer. And mean recruitment age was 63 years old. And these days, I mean, it's easy to look back. These days, you would not even consider a 63-year-old on any estrogen replacement therapy or hormone replacement therapy. The Million Women Study is an observational study on the use of HRT and non-use and the risk of breast cancer. prospective cohort study set up within the National Health Service breast screening program in the UK, conducted between 1996 and 2001. And they studied about 1 million postmenopausal women. They aged between 50 to 64, and they were free of breast cancer at baseline. And they were followed up for 2.6 years for incidence of breast cancer. And here are the results. Incidence of breast cancer after 2.6 years. Estrogen only, relative risk, 1.3. When you have the estrogen progestin combination, 2.0. Progestin only therapy, 2.02. Tibolone, 1.45. And the overall breast cancer mortality relative risk was 1.22. So the case, there's still a place for HRT, I believe, and the lead author of the WHI heart report was quoted as saying, I think it's going too far for the study to be interpreted as saying hormone therapy has absolutely no role in clinical practice any longer. Nothing about this study should preclude women who need the hormones to take hormones unless you are at a high risk. So I conclude that we have to study the risks and benefits of HRT and the individual needs and the individual risk profiles before we consider HRT on a case-to-case basis for the particular woman. So today's situation, patients are turning up for treatment for their vasomotor and other menopausal symptoms. If you need it, you need it. And there should be an individualized HRT for each patient based on her health status and potential benefit versus risk ratio. So to throw more things into the spanner, weighing the risk, now you've got venous thromboembolism, higher incidence of stroke, dementia, coronary heart disease, and breast cancer, as per the WHI study, versus the benefits, climacteric disorders, and you benefit from osteoporosis prevention. This is from the Times, 2004. One of the leading researchers behind the study said that benefits for a woman suffering menopausal symptoms far outweigh the risk. So I'm not saying that you should take HRT, but you have to individualize it for each patient based on their risk-benefit analysis. And Dr. Johnson said that there are many women for whom HRT continues to be an excellent choice for the treatment of menopause-related symptoms. In my clinical practice, I'm putting a lot of women on HRT. I graduated about when I was 26, and my mum happened to be menopausal then, and I put her on it for about 10 years, and she's now in her mid-80s, and I believe she's benefited greatly from HRT. So today's recommendation on HRT, use the lowest dose for the shortest duration, generally a 6 to 12-month period. However, longer periods may be needed for persistent symptoms up to 5 years, and you review annually. And lower doses are being made available since the WHI publication. Thank you for listening to this series. I trust that it's been informative and helpful, and do share this series of videos with people who may find it beneficial.